Hello, everybody. Hope that everyone is enjoying the conference so far. Welcome to this year's State of Neuropalliative Care Science Address. We're really pleased to be able to present today. My name is Dave Huang. I'm one of the co-chairs of the INPCS Research Committee, and I'm a neurointensivist at the University of North Carolina School of Medicine in Chapel Hill. I'm so delighted today to be able to present with one of our other co-chairs for the Research Committee, Anna Maria Branciani, who's the founding director of the Center for Health Outcomes and Interdisciplinary Research at MGH. We're really pleased to be able to present the second annual address on behalf of the entire INPCS Research Committee. Just to start off, neither myself or Anna Maria have any relevant conflicts of interest with this particular talk. And we'll go ahead and jump into it. So here's our talk outline for today. We subtitled this for this year's address, Where We Are and Where We Need to Go. And that's how we're going to divide up the talk today. I'm going to start off by talking a bit about where we are with regards to neuropalliative care research. Similar to last year's address, we're going to do a review of selected neuropalliative care research studies, and we'll focus primarily over the last calendar year. There's a lot of different neuropalliative care studies across different subspecialties, and to try to keep it organized, I'll divide up the talks between inpatient and outpatient talks, and we hope that you find the survey useful. With regards to where we need to go, Anna Maria will share some comments after the first section is over, just about conceptual and methodological opportunities for moving neuropalliative care science forward. Anna Maria's expertise is in psychosocial interventions, so that will be her focus. But the concepts that she's going to put forward and the ideas will be broadly applicable to neuropalliative care research in general. So we hope that you find this talk helpful and informative, and we're both looking forward to the discussion after the talk is over. So let's get started with the first half about where we are in a review of the 2021-22 studies. I'll start with just a few opening notes. First off, I'll just recognize that last year's great address by Claire Kreutzfeldt and Darren Zaharnik mostly focused on 4 randomized control trials, high quality trials that were conducted between 2019 and 2021. And I will say, in terms of reviewing literature over the past calendar year, there are few neuropalliative care randomized controlled trials over the past year, certainly that are powered for efficacy. So for this year's review portion of the address, we're going to open up the different types of research that we talk about. We'll include observational research in this year's talk, and that includes a few qualitative studies that caught our eye as well, that we felt that highlighted important issues with regards to neuropalliative care. As I mentioned before, we'll split it into inpatient and outpatient studies. I'll present 4 different inpatient studies and 3 different outpatient studies. And this is not meant to be a comprehensive review. We'll give the same disclaimer that Claire and Darren gave last year. And the majority of these talks were crowdsourced from our INPCS Research Committee with regards to what folks found interesting and of impact. And even though this isn't a comprehensive review, we do hope that all of you attending the conference will find this hopefully a helpful survey in terms of what's been out there over the past year. Now, because we're going to be covering 7 studies, the focus of this talk will primarily be on the quote-unquote headlines of the studies. Many of these studies are very, very rich with data and ideas, but we're really going to focus on sort of the main concepts that the authors put forward. And the hope actually is that for these studies are put forth, if the authors, if those of you who have authored the studies, have your studies presented today, that we hope that many of you will be a part of the discussion after the talk is over, and we can sort of dive in deeper with questions that people have and can highlight other aspects of your studies that we may not have necessarily highlighted in sort of this quick review. All right, so let's get started. We'll start with the inpatient studies. So we have 4. This is inpatient study number 1 for our review. This is a paper that was published in JAMA Network Open and is entitled Racial and Ethnic Differences in Hospice Use and Hospitalizations at the End of Life Among Medicare Beneficiaries with Dementia. This is a nice epidemiological study that was conducted by a group at Tufts. This is a retrospective observational study utilizing data from a large Medicare, Medicaid, health and retirement study. And what these authors did was they looked at 5,000 patients who had diagnoses codes of dementia and who died between 2000 and 2016. They took this large group of patients and stratified patients by race, and they looked at different types of healthcare inpatient utilization over the last 180 days of life for the patients that were included. So let's take a look at what they found. I'm presenting here table 2 from the study, which is the unadjusted correlations between different types of race and ethnicity with regards to different types of inpatient utilization. There was a multivariate analysis too, but I'm presenting the unadjusted just for sort of ease of conversation here. So we'll take a look and go down this. You can see at the top row, you can see the different types of respondents, all respondents, non-Hispanic, white, non-Hispanic, Black, and Hispanic. And in the first column, you can see the different types of end-of-life services that the researchers looked at. And I'll just highlight a few of the different rows that came out. First, with regards to hospice care in terms of services, they found a significant difference with regards to non-Hispanic Blacks in their study with regards to any hospice enrollment. That is, they found that non-Hispanic Blacks had a lower rate of any hospice enrollment compared to Hispanics and non-Hispanic whites in their cohort of folks in the database. Going down the table, with regards to ED visits, they found a difference between racial groups with regards to both any visit to the ED after hospice enrollment and then any visit to the ED during the last 180 days of life. You can see here the numbers that there was a higher utilization of the ED amongst non-Hispanic Blacks and Hispanics compared to non-Hispanic whites. And then going down the table to inpatient hospitalization, the authors looked at any hospitalization, inpatient hospitalization after hospice enrollment, and also any hospitalization independent of before or after or any hospice enrollment. And again, you can see that the numbers, the rates, percentages are higher amongst the non-Hispanic Blacks and Hispanics compared to the non-Hispanic whites in the cohort. So this was a large study looking at these ethnic disparities. And what the authors concluded was that work needs to be done to promote culturally competent end-of-life care with regards to dementia patients and reduce low-value interventions during the last few months of life. The advantage of this study is a very large cohort over 2 decades. We will point out one limitation is that as with any sort of database study, one is sort of beholden to the codes that folks have their diagnoses recorded under. There is a possibility with these types of studies of undercoding of dementia diagnoses in the cohort. And this possibility is particularly notable amongst non-white patients and in theory could potentially skew the data. Nevertheless, this is a great large epidemiological study that sort of highlights the challenges we have in neuropalliative care with regards to equity and cultural competence. All right, let's move on to inpatient study number 2. This one was also published in JAMA Network Open last year, and this one was entitled Assessment of Discordance Between Physicians and Family Members Regarding Prognosis in Patients with Severe Acute Brain Injury. This was a mixed methods cross-sectional study performed by Claire Kreuzfeld's group at the University of Washington. It looked at families, physicians, and nurses of about 200 patients or so that were admitted to various ICUs at their institution. These are all patients admitted with severe acute brain injury. And these patients, families, physicians, and nurses of patients, I should say, were all enrolled between day 2 to 7 of patient hospitalization. Now, all these different participants, the families, physicians, and nurses, were asked about the likelihood of the respective enrolled patient recovering to independence from 0 to 100 on a visual analog scale. In other words, they gave their prognosis. Each of these different groups of clinicians and families gave their prognostic estimates of how they thought the patient would do long term. And this study was primarily focused on discordance, which is defined as greater than 20% of a difference in prognostic estimate between the families and the physicians for this particular study. And predictors of that discordance, of that severe discordance, were analyzed, as we see here on this next slide. I've taken figure 2 from the study where Claire's group put forth the adjusted associations for different types of discord. We'll focus on discordance. This table included different types of discordance, which we'll get to. But this is primarily focused, what I'll present here on the slide is the portion of the table that's focused on discordance as we just defined. They found several different associations of different patient and family characteristics that correlated with a greater than 20% discordance between the family and the physician with regards to prognosis. The first association was family members who are in a minoritized racial group. Interestingly, when they looked at family member relationships, they found that when the family was a sibling or an adult child of the patient, that was more predictive of discordance than compared to if the family member was the patient's spouse. Finally, they asked nurses about their perception of how they thought the family understood prognosis. And for those patients for whom the nurses rated this family understanding as fair or worse, this is also predictive of discordance between the physician and family. Now, as I mentioned before, in addition to straight up discordance between the patients, in addition to straight up discordance between the patient's physician and the patient's family, Claire's group actually cleverly looked at a number of different other aspects of discordance. Namely, as part of the survey, the families were not only asked about their own impressions of prognosis, but they were also asked about the physician's, about their impression of the physician's predictions as well. In other words, what the family's perception of how the physician thought about prognosis was something that the families were asked on their surveys. And this really, I think, gave Claire's team a lot of rich data. I'll just highlight a couple things. First, they were able to look at misunderstanding, which is the difference between the family's perception of prognosis, of the family's perception of physician prognosis versus the physician's actual prognosis. That's what they defined as misunderstanding. And they were able to find that 46% of patients had families with this sort of misunderstanding as defined, as I just mentioned. They were also able to look at optimistic belief amongst families, which was the family's own perception of prognosis compared to the family's perception of physician prognosis. And they found that an optimistic belief difference was present for 54% of families, a very, very high number, consistent with studies that have been done in general critical care literature. So as you can see, this is a very rich study. I'm only sort of skimming the surface of some of what they found. There have been multiple follow-up studies as well. But for this particular study that was published in JAMA Network Open, Claire's group concluded that strategies are needed to reduce discordance between physicians and families for patients with severe acute brain injury in the ICU. One limitation of the study is that the surveys were given without any sort of particular coordination to when physician family meetings or provider family meetings were happening. So this might have increased the percentage of families who were expressing discordance simply because it wasn't clear from the study that a family meeting had actually occurred at the time of study enrollment. Okay, so we're going to move on to inpatient study number 3. I'm very happy to say that I really enjoyed collaborating with Susanna Muschlegel at the University of Massachusetts on this particular study, and I'm happy to sort of present this on behalf of both of us. We entitled this particular study, Pilot Randomized Clinical Trial of Goals of Care Decision Aid for Surrogates of Patients with Severe Acute Brain Injury. And this was a feasibility study. It was a parallel arm, unblinded, pilot randomized control trial of 66 family members with a variety of different severe acute brain injury diagnoses, acute ischemic stroke, particularly hemispheric acute ischemic stroke, intracerebral hemorrhage, and traumatic brain injury. And all the patients whose families were enrolled in the study were likely to require trach and peg early on in their ICU stay. The participants who were the family members of these patients were randomized to using a new paper-based decision aid that was developed through Susanna's K Award prior to participating in a formal goals of care family meeting in the ICU. This paper-based decision aid is designed to sort of go through relevant issues regarding shared decision-making for these patients in the ICU, such as the definition of trach and feeding tube, the individual patient's prognosis as defined by common clinical grading scales, and what comfort care versus potential facility placement might look like for the patient sort of down the road. Now, the study was only powered for feasibility and acceptability. It's not an efficacy trial. This is a pilot trial. But we're happy to share the following findings. We found that 93% of those folks in the study who were randomized to the intervention arm did read the decision aid and were able to read it amidst the craziness and the stress of the ICU. And we collected some acceptability data with regards to those who participated in the intervention arm. You can see here from graph A that 82% of those who were in the intervention arm who participated with the decision aid found that this decision aid was good or excellent. And you can see a number of other different acceptability markers in panel B. Particularly, I'll point you to the first one that folks, 96% of folks endorsed that they found the decision aid useful when making a decision about goals of care for their family member. We did do a 3-month follow-up of exploratory outcomes for all the patients who enrolled in the study. We found that 68% of all participants were able to complete that 3-month follow-up of exploratory outcomes, which is for sort of further demonstrating the possibility of potential for a larger trial. So our conclusion for this particular study was that a goals of care decision aid for severe acute brain injury patients' families is feasible to utilize in the ICU with good acceptability, and that a larger trial is indeed possible. Now, we will sort of point out some caveats from our exploratory outcomes, which will require some future thought. The first thing is that we found that even with our small study, the decision aid group had trended towards fewer comfort care decisions and code status changes. In other words, more folks in the decision aid group decided to pick prolonged medical care. And what we found is across both the intervention group and the control group, those surrogates who had selected prolongation of care or who had decided not to make their low and comfort measures had worse psychological 3-month outcomes with regards to anxiety, depression, and PTSD compared to those surrogates who had chosen, compared to those surrogates who had chosen comfort care. So I think what this speaks to is that even though this intervention is possible, that the outcomes for a possible future larger trial, they will definitely need to be carefully selected as we sort of think about what outcome is the most relevant and how to power it. Okay, and this is the last inpatient study that I'll present today. This one is entitled Prognostic Discussion for Infants with Neurologic Conditions, Qualitative Analysis of Family Conferences. And this is led by Monica Lemons and her group at Duke. This is a descriptive qualitative study of 68 audio recorded family conferences in the ICU regarding prognosis for infants less than 1 year old. And to give you a sense of the types of infants whose families were included in this study, the different types of conditions include prematurity, genetic conditions, and brain malformation. This is a very, very rich study with regards to the types of quotes. I really encourage you to read the paper yourself. I will just highlight a few of the themes that Monica's group pointed out. There are 2 major themes regarding prognosis. First, with regards to the predictions of impairment, and then the rationale for those prognostic predictions that came up repeatedly in these audio recorded family conferences. There are also 3 themes regarding the role of prognostic decision that came out. First, aligning parent and clinician understanding of infant outcome. Second, influencing decision-making. And third, preparing for life at home. Now, interestingly, they found 2 themes that were that had to do with prognostic uncertainty. And they found that this was very multi-layer. I just wanted to highlight a few of the layers that they uncovered. They uncovered uncertainty regarding whether the infant actually had a neurodevelopmental impairment, and that in other words, the diagnosis itself. There's uncertainty regarding the cause of the impairment, why that impairment was there, why the patient had an impairment, and then finally uncertainty regarding the future severity of that impairment and what that meant for that infant's life. And so this multi-layer bit was a difficult thing, I think, for folks to grapple with. It's a difficult thing for folks to grapple with in these conversations that Monica's group was able to explain and give examples for. And then finally, a theme of holding space for hope alongside uncertainty as providers try to counsel these families. The conclusion that Monica's group had was that additional work is needed regarding understanding patient preferences for prognostic disclosure and exactly when and how these different conversations should happen. But as I mentioned, this is a rich qualitative study that really sort of deserves a read through to really capture all that Monica's group uncovered. Okay, let's move on to our outpatient studies. So this is outpatient study number 1. We have 3 studies that we'll be putting forth today. This one is pivoting a little bit from the general themes of what we've been talking about. This one was entitled Safety and Efficacy of an Equimolar Mixture of Oxygen and Nitrous Oxide, a randomized control trial in patients with peripheral neuropathic pain. So this is actually a drug trial. This was an international, multi-center, placebo-controlled phase 2 randomized control trial conducted in Europe. It was among 20 centers in France and 2 in Germany. The study authors, this proto-top group, randomized 280 patients with peripheral neuropathic pain from a variety of different etiologies to an intervention and control group. The intervention was inhaled mixture of nitrous oxide and oxygen. This IMONO is the acronym that the authors use. Nitrous oxide is a methyl aspartate inhibitor, and is used in a lot of variety of different outpatient settings. And the way they used it in this particular study was they gave these patients with peripheral neuropathic pain in the intervention group 3 consecutive daily 1-hour administrations in an outpatient setting. So there's 3 consecutive days. And compared to the control group, they sort of looked at different pain outcomes over a period of a month. And so I'll share them with you here. For these 2 different graphs, these are 2 different types of measurements of pain. And I think this study sort of demonstrates the challenges of conducting pain research and patient-reported outcomes. For both of these graphs, we'll focus first on the one on the left, or pain intensity. The blue is data from the IMONO group, the intervention group, and gray is from the placebo group. That first panel A shows measurements of pain intensity at different weeks in the study, as measured by the neuropathic pain symptom inventory, which is scored from 0 to 10. What they found was there's no significant difference in using this specific neuropathic pain symptom inventory with regards to the 2 treatment groups at any of the different weeks, the 4 weeks following the intervention. On the other hand, when they looked at a different outcome, which is this patient global impression of change, patient-reported outcome, they did find a difference that was significant in weeks 2, 3, and 4. Now, this particular instrument is simply a 7-point scale where folks rate their pain as compared to baseline as anywhere from very much improved to very much worse. And it's sort of on a 7-point Likert scale. And for those that, for any of the data point, any of the selections points on the scale that correlate with improvement, those were all put in one bucket and dichotomized. And that's what you're seeing here in panel D as those folks who rated any sort of improvement on that PGIC. And they were able to find a significant difference with regards to 2, 3, and 4, weeks 2, 3, and 4 with that particular metric. So again, sort of the challenges here with regards to palliative care studies and looking at patient-reported outcomes and pain. So the conclusion that the authors drew here with this study was that these are preliminary results. They will need further study. And there is significant uncertainty with regards to the efficacy and safety of prolonged repetitive treatments. In other words, they were just looking at this one protocol of sort of 3 consecutive days of treatments. But in terms of continuing them at a sort of those treatments at a later time point or more numbers of days up front, these are all sort of permutations of the intervention that require more study. Now, one particular limitation with this study, or challenge, I should say, was the IMONO system and the placebo administration systems actually do look slightly different in practice. And so there's some concern that there's challenging with the blinding with respect to the patients participating. Although the authors did report that when asked, only 50% of participants are able to correctly identify their study arm in the study, which is about a 50-50 chance. Okay, we have 2 more studies we're going to present. And both of these actually are I should say, sub-studies or secondary studies from a large randomized palliative care trial for Parkinson's patients. This is a Benzie study that Claire and Darren presented first at the State of the Science address last year. I think many of you are familiar with it. And we just wanted to end this portion of the talk by presenting two interesting sub-studies that have come out of that same data set. The first one is this study by Lindsay Preiser and Janice Miyasaki's group. This is the presence of a caregiver is associated with patient outcomes in patients with Parkinson's disease and atypical Parkinson's. This is an exploratory cross-sectional secondary analysis of 210 participants from that palliative care Parkinson's trial that I mentioned earlier. And what they did was they looked at patients who had a caregiver and patients who did not have a caregiver in the study. And they looked at a whole host of dependent variables, including measures of patient's functional status and cognitive, quality of life, psychological, and spiritual assessments. This is a table from the study. I'll sort of lead you through what they found. The first thing to note, you can see a bunch of different measures that were from the study. The first thing they found, if you look at the top, there's two sets of columns. There's the patients with caregivers and patients without caregivers. And what they found was that for measures of functional status, motor function, and cognitive function, that those patients with caregivers had worse motor function and cognitive function, to sort of just in terms of their sort of baseline with regards to the study. Similarly, when we looked at the palliative performance scale, which is a measure of palliative care needs, patients with caregivers tend to have higher palliative care needs than patients without caregivers. And then despite their sort of decreased motor function, their lower cognitive function, and their increased palliative care needs, when they looked at measures of spirituality, they found that those patients with caregivers had higher degrees of spiritual health, if you will, compared to those without caregivers. And then with regards to quality of life, in this particular cohort, those Parkinson's patients with caregivers rated a higher quality of life than those without caregivers. This is despite sort of their less healthy baselines, if you will. So we found this study interesting just because there's not that many studies that really really try to get at the sort of impact of patients' caregivers on patients' health, which is really important. And so the conclusion of this particular study was that the presence of a caregiver may be an important modifying variable on patient outcomes of interest in neuropalliative care. This is sort of a preview of some of what Anna Maria is going to put forth in a little bit regarding future dyadic and triadic interventions. Now, for this particular study, it is important to note that this is an exploratory analysis of a convenience sample from a prior study, and so not necessarily proof of causality, but we felt like it was worth highlighting simply because of the concepts that it was putting forth, these principles for neuropalliative care. Okay, this is the last study that we're going to present, patient study number 3. And as I mentioned before, this also was a sub-study from the palliative care and Parkinson's disease clinical trial. This one was entitled Lessons from the COVID-19 Pandemic for Improving Outpatient Neuropalliative Care, a qualitative study of patient and caregiver perspectives. As much as all of us are tired of the pandemic, there's no question that the pandemic had a profound effect on healthcare delivery. And so the study we found was very timely with regards to the concepts that it approached. This study was a qualitative descriptive study, leveraging data collection from that multi-center trial that we mentioned. And it looked at a wide variety of data sources from 100 patients and 90 caregivers in that study. These researchers, led by Zach Mackey, looked at audio recordings of study participant interviews. They looked at patient and family responses to open-ended survey questions from that larger trial. And they even looked at the medical records to look at palliative care follow-up notes and even communications that had been passed along between the participants in the study team throughout the trial. So from looking at all these different data sources throughout the trial, Zach's group identified 4 major themes that came out with regards to COVID and palliative care and neuropalliative care. The first is that patients and families really reported disruptions to the delivery of healthcare. and other supportive services throughout the pandemic. The second was an increase, despite these disruptions, an increase in symptomatic and psychosocial needs, very important for the second half of this talk. Increased caregiver burden. And finally, limitations of telecommunications when compared to in-person contact. So the conclusion here that Zach's group drew was that changes to neuropalliative care delivery in response to COVID-19 must be addressed to optimize in the future. And I think the study highlights what many of us recognize. I think that all of us are relieved to have tried to come out on the pandemic on the other side. The pandemic itself, right, is still affecting society, and it seems to have put forth changes with regards to neuropalliative delivery that our field will really need to think about very hard as we're sort of designing interventions moving forward. All right, so those are the 7 studies that we decided to summarize. Again, these were just sort of going through the headlines of the studies, and we're hopeful that that many of you who are authors of these studies might be able to participate in discussion afterwards. Just to sum up this half of the talk, we'll say that hopefully you felt that there was a broad range of studies with regards to neurologic subspecialties and research methodologies. This year, again, we included the observational and qualitative studies that are so important for generating hypotheses and generating ideas for trials in the future. We will say that there are a few large trials of novel interventions over the past year, especially those that sort of move beyond the sort of stage 0 to 1 of the NIH model for intervention development that Anna Maria is going to talk about, that really sort of push towards developing efficacy and eventually implementation. We'll say that these larger trials, when they are conducted, they do create opportunities, as we've seen, for valuable further exploratory analyses. And so there's clear opportunities for our future as a field with regards to research growth and trying to think about strategies and methods to develop our research and push towards trials that could potentially impact care and develop be a grounds for future research and discovery. So I hope you found this half of the talk helpful, and I'm very pleased to be able to turn it over to Anna Maria for the second half of the talk about where we're going as a field in neuropalliative care research. Thank you guys so much.
Thank you, Dave, for a wonderful review of the neuropalliative care research over the past year. And thank you all for being here today. I am truly honored to share some thoughts on conceptual and methodological opportunities to improve our neuropalliative care science. I hope that these musings can spark a conversation around how we can work together and learn from each other so that we can develop better and better evidence-based solutions to support our neuropalliative care patients and families. I have a disclaimer. I am a clinical psychologist, so much of what I will be talking about comes from my perspective as a psychologist, though I hope to convince you, if convincing is needed, of the important role of psychosocial and behavioral interventions in neuropalliative care. The focus of this talk will be on discussing the important role of psychosocial interventions as part of neuropalliative care, the opportunity and challenges of dyadic and triadic interventions, so interventions that include both patients and care partners, as well as patient, care partners, and providers, the less explored opportunity of prevention in neuropalliative care, the importance of using the NIH stage model as our GPS for conducting intervention research, the importance of testing and understanding mechanisms for neuropalliative care interventions, the role of measurement in being able to demonstrate the success of interventions, the role of transdiagnostic processes in facilitating implementation and dissemination of neuropalliative care interventions, and the benefits of developing interdisciplinary models of care that encompass clinical, training, and research. And I will end with some thoughts on how INPCS has been facilitating neuropalliative care research and additional suggestions for how we can further improve our science. So a large body of research shows that behavioral patterns are important predictors of quality of life. Behavioral patterns, things like illness appraisal, coping, interpersonal communication, adherence, and emotional distress, are all modifiable through psychosocial interventions. When we look at the neuropalliative care research, we also see that these behavioral patterns are important predictors of quality of life and well-being across illness trajectory. Addressing these behavioral factors that are common in patients and caregivers with serious neurological illness is an important opportunity to improve quality of life and also improve more proximal outcomes, such as ability to engage in shared decision-making, discussions around goals of care, and advanced care planning. However, these behavioral patterns are not routinely assessed or addressed in our patients and families with serious neurological illness. And so, within neuropalliative care, prioritizing psychosocial interventions that address these modifiable factors, including coping, illness appraisal, and symptom management, has the potential to have a huge impact on the quality of life and well-being of our patients and families. Much of the neuropalliative care research is focused on patients and more recently on caregivers or care partners. Dyadic interventions where patients and caregivers participate together represent an important opportunity to support patients and caregivers who we know are both impacted by the disease. We also know that the patient and caregiver factors are interdependent over time, such that my coping and psychosocial functioning as a patient impacts my caregiver's coping and psychosocial functioning over time, and vice versa. Dyadic interventions have several advantages. They are economical because both individuals are seen together at the same time. Also, they tend to be more potent than individual interventions because patients and caregivers learn the same skills and can use them together to manage symptoms and make decisions together across the illness trajectory. From a methodological standpoint, however, there are challenges because for true dyadic interventions, the same outcome measures should be used for both patient and caregivers, and we don't have great measures that apply to both patients and caregivers. Thus, an important priority in neuropalliative care research is developing or curating measures that can meaningfully address the constructs we measure and also can be used in dyadic research. In addition, triadic interventions where patient, caregiver, and provider work together are receiving a lot of attention from NIH as an opportunity to improve patient-caregiver-provider communication. There are several dyadic and triadic frameworks to guide the development of dyadic and triadic interventions, and two are referenced on this slide. And so prioritizing dyadic and triadic processes, measurement, and psychosocial interventions is an important opportunity to improve outcomes within neuropalliative care. So few of us associate neuropalliative care with prevention, and most of us think about palliative care as end of life. However, the World Health Organization definition of palliative care has a focus on prevention. And a systematic review in 2007 drew attention to the possibilities of early palliative care focused on prevention. However, most neuropalliative care trials continue to be focused only on late stages of disease and end of life. Developing psychosocial support interventions focused on prevention, including interventions that are delivered immediately after diagnosis, can set the stage for an improved illness trajectory. For example, addressing emotional distress at diagnosis disclosure provides an opportunity to teach emotional regulation skills so that patients and caregivers can better communicate, access resources, and engage in long-term care planning. There is also an opportunity to teach skills around managing symptom progression and engaging in value-based living. We also know that, particularly in dementia, neurologists often stray away from giving a definitive dementia diagnosis because of concerns about impact on patients and families. Early interventions can support neurologists with making the diagnosis and can give time back to patients and caregivers. And so early neuropalliative care interventions, ideally starting a diagnosis, would allow us to be proactive rather than reactive and could be more successful than those focused on late-stage diseases. And the Center for Disease Control Prevention framework can help us think about broadening the scope of our neuropalliative psychosocial interventions so that we can be more proactive rather than reacting in how we help our patients and families. The framework specifies care as primary, secondary, and tertiary. Within primary prevention, we can think of interventions for caregivers who are healthy but are at high risk for morbidity and mortality due to the stress of caregiving. The goal here is to preserve health, promote health, and prevent illness. We can also think about interventions for patients who have a known genetic risk for a neurological illness. Within secondary prevention, we can think of interventions for patients, caregivers, or dyads where there is heightened emotional distress after diagnosis. The goal here is to prevent transition from acute to chronic emotional distress. And most of our neuropalliative psychosocial interventions are focused on tertiary prevention, where we work with patients in later stages with chronic distress or end of life. And so moving our clinical research toward primary or secondary prevention is an important opportunity to set the stage for improved quality of life over the course of illness. When we look at our neuropalliative care trials of psychosocial interventions, few are mapped onto the NIH stage model. The NIH stage model is our GPS for intervention development and clinical trials. It allows us to do good science because it provides clear benchmarks and guidelines that allow us to move from stage 0 to 5, from intervention development to implementation. Following the steps of the model allows us to develop efficacious and potent interventions that are implementable in routine care. And very briefly, stage 0 is focused on hypothesizing mechanisms of the intervention, so thinking about why and how an intervention might work. Stage 1 is focused on developing and refining an intervention with qualitative methods and an open pilot with the goal of showing that an intervention has feasibility and engages our mechanistic targets. In stage 2, we test efficacy against the control. In stage 4, we test effectiveness in real-world settings with lax inclusion and exclusion criteria. Stage 3 is called efficacy effectiveness. And here the methodology is in between stage 2 or 5 or 4. And in stage 5, we focus on implementation and dissemination. And so mapping our neuropalliative care interventions onto the NIH stage model will be important in order to increase the rigor of our science and opportunities for funding. The NIH just released the revised NIH stage model, and institutes are now particularly focused on applications that are using the NIH stage model to guide intervention and clinical trials. Related to the NIH stage model is the importance of focusing our work on understanding mechanisms for our neuropalliative care psychosocial interventions. So understanding why and for whom an intervention works. When we look at the neuropalliative care trials, very few assess mechanisms. So we don't know why an intervention works or does not work. Knowing why an intervention works, so knowing the mechanisms, allows us to be able to implement that intervention with fidelity and also to develop potent interventions where we eliminate the components that don't add much to improvement in outcomes and prioritize those that are most important for improvement in outcomes. The Science of Behavioral Change is a wonderful NIH-funded organization that has great information and guidelines around how to identify what is the most likely mechanism to investigate, how to measure the mechanism reliably, and whether an intervention can reliably change the identified mechanism. Within the NIH stage model, we can hypothesize our mechanism, assess whether our intervention changes our mechanistic target, test for mediation and moderation, and also test our implementation mechanisms. So our opportunity is to prioritize understanding and testing mechanisms of neuropalliative care interventions so that we can optimize them and implement them in routine care. A related aspect is how we measure our mechanistic targets and our outcomes. We know that we want to have valid and reliable measures that are meaningful to our stakeholders. We also want to collect feedback on stakeholder perceptions of questionnaires. However, an important and neglected aspect of measurement is matching the theoretical framework with the skill we are teaching in the intervention and the specific measure we use. So for example, let's take a neuropalliative care intervention where we are targeting improvement in dyadic coping in order to decrease emotional distress in patients and caregivers. So here, our theoretical mechanism might be the systemic transactional model that posits that within dyads, stress comes from each partner, but also from the interaction between the partners, including how they cope with stress together. This model is directly linked to the measure we would choose, which is the dyadic coping inventory, which was developed specifically based on the systemic transactional model. And the skills we are teaching are directly focused on individual and dyadic coping, or the I and we coping, communication and problem solving. And these are directly mapped onto the dyadic coping inventory, which we're using to measure our outcome. So in this way, by aligning theory with skills and measures, we increase confidence that our intervention is going to be associated with improvement in dyadic coping. So by ensuring that theory, skill, and measures are matched, we can improve our ability to show that our intervention works. Also, in many instances where our trials are negative, improvements may be present, but we are not able to detect them because of our measurements, because our skills are not based on our measurement, or they're not captured by our measurement, and because we are not using theoretical orientations for our interventions or for our measurements. A new opportunity depicted by the revised NIH stage model is around transdiagnostic processes. We currently develop psychosocial neuropalliative care interventions that are disease specific. So for ALS or dementia or Parkinson's. However, from a psychosocial standpoint, there are common factors that an intervention would need to address across these illnesses. For example, emotional distress, interpersonal communication, and symptom management. So our opportunity here is, when relevant, to prioritize neuropalliative psychosocial interventions that address common factors across illnesses. This would greatly support our goal of dissemination and implementation of our interventions. The last opportunity I would like to highlight is around our teams and models of care. Much of the work that we are doing is siloed, and often clinicians, researchers, and trainees from different disciplines don't interact as much as they could to create good science. At MGH, within the Neuro ICU, we developed an integrated model of care that started with a clinical collaboration between psychology and neurology, followed by interdisciplinary research that led to an intervention called Recovering Together. It also included development of a rotation for psychology trainees, and eventually led to a model of care for our current R01 efficacy trial, where the trial is fully embedded within routine care with interventionists that are trained. We take all referrals and triage them to the study when criteria is met, or provide brief at bedside interventions and supervision and training when study criteria is not met. This model has been highly successful. The medical team prioritizes referrals to the R01. Trainees are excited to provide clinical care, and nurses in particular are thrilled to be able to make referrals for bedside care. So our opportunity here is to merge clinical work, training, and research, and bring together interdisciplinary teams with different perspectives. INPCS has developed great initiatives to support science. We have a monthly work in progress session that is run by Darren and Zach. David and Winnie are leading a white paper. And we are also in the process of awarding seed grants to junior investigators, and Claire is leading an R13 submission. So lots of great things are happening at INPCS these days. However, there are also additional opportunities. We can learn from the Palliative Care Research Cooperative and perhaps submit a grant to develop similar resources in neuropalliative care. We can work towards training grants like R25s and T32s. We can develop INPCS conference workshops on methodology, as well as INPCS methods research webinars. So lots of opportunities for us to think about in terms of next steps to facilitate good science. So in sum, there are multiple opportunities to further improve neuropalliative care science with how we conceptualize our research, focusing on psychosocial intervention, early palliative care, prevention frameworks, focus on dyads and triads, our methodology, so using the NIH stage model, mechanisms and transdiagnostic processes and measurements, and our teams, focusing on interdisciplinary teams and merging clinical training and research. Thank you very much, and I am excited to take questions alongside David.
Wow. Thank you very much, David and Anna Maria, for an absolute tour de force there of research in the field. I can't think of a better way to spend 45 minutes. I might need to watch it a few more times to pick up all the tips. So we've so just a reminder to pop your questions, please, in the question function, so we can get those out. And before we go to questions, we've got Darren Saronic, who's coming to tell us about the seed funding award from INPCS.
Yeah, great. Thank you very much, Ed. So I'm one of the co-chairs of the INPCS Research Committee, and just going to make a brief announcement here that we're very pleased to have been able to offer funding for 2 seed grant applications to support the work of junior investigators this year. I want to thank the board for supporting funding this effort, as well as the volunteer members of our review group who put in their time to look at the multiple excellent applications we had this year. And while I wish we would have had the resources to fund all of the submissions this year, we're thrilled to be able to support 2 of these awards. And so I'd like to announce that the 2 winners of our inaugural seed funding awards this year are Dr. Winnie Lau of the University of North Carolina, Chapel Hill, and Dr. Hina Manglani from Harvard and MGH. Dr. Lau's presentation is entitled "The Role of Inpatient Hospice for Mechanically Ventilated Patients with Severe Acute Brain Injury." Dr. Manglani is going to investigate the first year of multiple sclerosis, investigating predictors of chronic emotional distress in patients and care partners. And unfortunately, Dr. Lau was not able to join us today, but I see that Dr. Manglani was able to join us on screen briefly for us to recognize her and congratulate her. And we really look forward to seeing the results of both of these projects in the future.
Much.
Fantastic, congratulations. Yeah, judging by the presentation we've just had, then it's a rapidly growing area of interesting research, and well, hopefully this time, maybe next year, the year after, how long, I don't know, a few years' time, we'll see your research presented here, hopefully. Thanks so much to Darren. So we'll move on to some questions. And so we've got David and Anna Maria to take these. Do pop more in as we go through. First question, can you talk some more about the Recovering Together intervention, please?
Yeah, absolutely. So first of all, the pilot feasibility trial is published in JAMA Network. So if you want to read the entire paper, you can definitely find it in PubMed. So we developed Recovering Together to support patients and caregivers in the neuro ICU, primarily to prevent the development of chronic emotional distress in both the patients and the caregivers. Obviously we know that depression, anxiety, and PTSD are huge problems, in the neuro ICU, and so we really needed a solution. So we did follow the NIH stage model, which I mentioned, did a lot of qualitative interviews with patients and caregivers, did an open pilot, iterated the intervention. So the actual intervention is 6 sessions long. It has 2 sessions that are delivered in the neuro ICU to both patient and caregivers, which are focused primarily on deep breathing, dialectics, so helping patients and caregivers hold on to different emotions that are contradictory, helping them stay in the 24 hours rather than thinking about worst case scenarios or what's going to happen in the future. And then we have 4 sessions that are delivered to the patient and the caregiver after the patient is discharged, whether the discharge happens in the rehab or at home. And the nice thing about doing the sessions virtually is that the patient can be home on one iPad, and then the caregiver could be at work or somewhere else, on a different device. And these sessions focus on helping patients and caregivers learn how to communicate with each other, talking about role changes that often happen, after an acute neurological event, talking about fear recurrence, making meaning out of the experience, as well as learning symptom management. And so we found really good, great feasibility, acceptability, and pretty strong effects for the intervention being superior to our attention placebo control, which was just an educational intervention in improving depression, anxiety, and post-traumatic stress, and sustaining this improvement at 3 months. So we're doing a big R01 efficacy trial right now. So 5 years from now, hopefully we'll have great results.
Fantastic, thank you. Could I ask a little bit about, I was intrigued about the dyad, triad interventions, and I think particularly for patients with more chronic diseases, I'm thinking of Parkinson's disease and MS, things like that, those dyads, as a clinician, I'm really aware of how important those dyad relationships are to maintaining well-being. Could you talk a little bit more about how future outcome measure development is going to need to consider that?
Yeah, I mean, the field of the triadic, interventions is pretty brand new. I mean, most of what we know from the triads of, parents and children. I think, more recently we've seen some communication interventions that are trying to address the patient and the caregiver and the provider. I think it's really nice that the NIH, particularly at National Institute of Aging, is very interested right now in triadic interventions, primarily for dementia. I think obviously our measurements are going to have to be different if we're thinking of a triadic intervention early after diagnosis, which is really one of my passion. I really think we need to intervene very early to prevent, bad things that happen later, and then also help people regulate emotions so that they can engage in tough conversations. I think later on, those, it's really hard, right? Depending on where you are with the progression of disease, whether you're talking about ALS or dementia, to truly engage the caregivers. But I think that there is the field of measurement here is wide open. We don't really have much, and we will really need to think carefully about measurement, because I think, as I mentioned in my talk, I think a lot of the times we do have good interventions, but we don't have good measurements to actually show that our interventions work.
Thank you. And when do you think you'd need to time those measurements? I'm just mindful that, so like this idea that, the way the diagnostic process then echoes down through the disease and people's ability to accept interventions and to assimilate, help, and to the way that they have health beliefs that then echo right down. And I'm sure we've all got patients who, in the end stage of their disease are still focused on their diagnostic consultation, and it's heartbreaking. And yet, in a disease like PD or something, to see those benefits, you're going to have, they're maybe 10 or 15 years away. So are there intermediary proxy measures along the way to look at, for example, positive or negative coping strategies that then we think will then be a proxy for those subsequent good outcomes?
Yeah. I mean, we do have, pretty good, coping measures. I think most of the research has been looking at sort of negative outcomes. But I think some of the folks in Benzi's groups actually are looking at, more positive affect and positive outcomes. I think it's also like, what do we consider, how do we define our outcomes? And also, I think it will be important to talk to our patients, our caregivers, and our communities to really understand what's important to them. And then to your earlier point, also educate our clinicians, right? And maybe provide them with a lot of support, particularly around diagnostic disclosure. We know that particularly in dementia, right? It's really hard to make a diagnosis because then you have to deal with all this emotional distress that's in the room. And so a lot of the times, that gets kind of pushed away, but being able to have psychosocial support right there, and maybe do a warm handoff to, someone who can kind of contain that emotion with a patient and families can be really helpful. And I do think that that's a really nice point to integrate psychosocial support, because there are some things that we could do right then to get buy-in, from the patients who, might later on defenses go up and you become avoidant. So, I think those early stages are a great opportunity for us.
Thank you. That's brilliant. We're up against time, but David, I'm mindful that I've not asked you a question. Could I just touch on, I haven't got the name, I'm sorry, because I was making quick notes, but the feasibility trial, which you mentioned, and I think you said that the decision aid, the trend was towards increased people choosing more intervention rather than less, which I guess is maybe the opposite to what was expected. Could you talk to us a little bit about how that might come about and how that might influence the subsequent trial design for the larger trial?
Sure, thanks, Ed. And I can be brief with time. I think it actually dovetails really well to the questions that you and Anna Maria were just speaking about. It's an intervention in the ICU that's sort of designed to help with shared decision making. But when we're looking at exploratory outcomes of 3 months, what we found is that there was a group of folks who, both in both intervention and the control arm, who in selecting long-term care, did have increased psychosocial adverse psychological outcomes at 3 months. And our hypothesis is that while folks may feel like they might benefit from this in the ICU, that's really just the beginning of the journey. It's just going back to your question about timing of outcomes and thinking about what the right outcomes are for an intervention like this. It's possible that as folks learn a little bit more about what rehab might be, that they might choose that that's what's best for them. But then in doing that, they then start on this journey of caring for someone who's severely disabled in many cases. And so the question, I think, as we think about what this might expand to if we were to pursue efficacy trials, I just think this question of what the right outcome is, what is the right timing to measure the outcome, it just couldn't be more germane to the points that you and Anna Maria we're just bringing up. So I think there's more story to tell. There's more thinking to be done about the right outcomes, about things that we may feel that have benefit, but trying to show that scientifically.
Brilliant. Thank you so much. I'm sorry that we're up against time. Guys, I'm well and truly inspired. We will have a short break now, and then we'll be back for the last session. Thank you so much.
Thank you.